Good morning, students. We will continue the topic acid-base balance, competition number 6.7, and today's topic is disorders associated with blood pH, acidosis and alkalosis, and their compensatory mechanisms. So, what is acidosis? It is a clinical state where acid accumulates or bases are lost. Remember these two. Acidosis means either increase in acid or decrease in bases of our body, and opposite to that is alkalosis, means loss of acid or accumulation of base. The body cell tolerate the normal range of pH. The extreme ranges of pH between 7 to 7.6 are found in some abnormal situation, and beyond which the life is not possible. That means if pH decreases below 7 or above 7.6, death is sure. Normally the pH ranges from 7.35 to 7.45, but body can tolerate up to this range. Now, classification of acid base disturbances. Acidosis, just I have told you, and alkalosis. Acidosis is of two types. Acidosis means fall in pH. Respiratory acidosis, where there is increase in the carbonic acid or primary excess of carbonic acid. Remember this. I have told you acidosis means increase in acid or loss of base. Metabolic acidosis means primary deficiency of bicarbonate, so loss of base. So acidosis, which is called as which is due to fall in pH, it is of two types: respiratory acidosis, metabolic acidosis. In respiratory acidosis, the weak acid, that is carbonic acid, increases, and in metabolic acidosis, the base bicarbonate decreases. Now coming to alkalosis, which is in which there is rise in pH. Again, it is of two types: respiratory alkalosis, metabolic alkalosis. In respiratory alkalosis, there is primary deficiency of carbonic acid. In metabolic alkalosis, there is primary excess of bicarbonate. So these are four different types of acidosis and alkalosis. One by one we will study these four. Before that, we will study a relationship between pH and potassium ion, which is very important to know you. In acidosis, there is hyperkalemia. Hyperkalemia means increase in the potassium level in blood, that is called as, or serum or plasma, that is hyperkalemia. Why there is hyperkalemia in acidosis? In acidosis, all of us know H plus ion concentration in the ECF or extracellular fluid increases. Now these H plus ions enter into the cell, and the potassium ions which are present inside the cell, they will come out in exchange, right? In acidosis, H plus ion in the ECF increases. These H plus ion enter into the cell, and in exchange the potassium ion, which is normally usually present inside the cell, will come out of the cell, and hence there is hyperkalemia. So this is important to remember. In acidosis, there is hyperkalemia, means increase in the potassium level of extracellular fluid, and these potassiums are coming from the cell. Remember this. Now similarly, in alkalosis, there is hypokalemia. The reason, there are two reasons here. First reason, alkalosis means decrease in H plus ion. So H plus ions present in the cell will come into the extracellular fluid. In that exchange, potassium ion from extracellular fluid enter into the cell, leading to hypokalemia. As there is alkalosis, there is deficiency of H plus ions. So kidney try to conserve the H plus ions in PCT. Remember the mechanism in PCT. So this is the mechanism which occurs in PCT, where H plus ion is excreted in exchange of sodium ions. So here in alkalosis, kidney try to conserve H plus ion. Therefore, kidney will not excrete H plus ion. Instead of it, kidney will excrete potassium ion in exchange with sodium ions. Therefore, there is loss of more potassium through the urine. So in alkalosis, there is hypokalemia due to these two reasons. So in general, remember, metabolic acidosis is associated with hyperkalemia, metabolic alkalosis is associated with hypokalemia. In hyperkalemia, the source of increased potassium is these potassium ions are coming from the cell, and in hypokalemia, this potassium from ECF entering into the cell. This point you have to remember. Hypokalemia is also seen in few other conditions, like first one is hyperaldosteronism, means increase in secretion of aldosterone. All of us know aldosterone is a mineralocorticoid. It acts on DCT and collecting duct and increases the absorption of sodium and causes increased excretion of potassium ions. So that is the effect of aldosterone enzyme. So in hyperaldosteronism, sodium ions are retained and potassium ions are lost due to the action of aldosterone. Next cause is diuretic therapy. Now what is diuretic therapy? Diuretic therapy is given in some patients of hypertension, where there is loss of fluid from the body through urine. That is called as diuresis. Now when there is loss of fluid from the body, all of us know the body is in hypovolumia. Whenever there is hypovolumia, the aldosterone secretion increases, and again the same mechanism, retention of sodium and excretion of potassium takes place. So diuretic therapy also called as hypokalemia, that you have to remember, because this diuretic therapy is very common in hypertensive patients. Next is renal tubular acidosis. Just now I have told you, in renal tubular acidosis, there is failure to excrete H plus ion by the kidney. See this mechanism. Here in this mechanism, kidney will excrete H plus ion and absorbs sodium ion, right? Now in renal tubular acidosis, kidney will not able to excrete H plus ions, but kidney has to absorb the sodium. So the kidney will absorb the sodium in exchange with potassium ions. So potassium ions are lost in the urine. Again, this is very important during treatment of acidosis. Patient comes to you, he may be in the acidosis. The causes of acidosis are numerous, that we have studied in the last lecture. So when you treat the acidosis, what will happen? The potassium ions which have causes hyperkalemia in acidosis, they are coming from the cell. When you treat the acidosis, all these potassium ions suddenly enter inside the cell and the patient goes in hypokalemia. So that hypokalemia you have to monitor, because sudden hypokalemia is also dangerous. Hence it is said that it is important to maintain the potassium balance during the correction of acidosis, especially in case of diabetes ketoacidosis, because diabetic ketoacidosis is the most common cause of acidosis in clinical practice. When you treat that in acidosis, there is hyperkalemia, but when you correct that acidosis, the potassium ions suddenly enter into the cell, because in acidosis they have come out of the cell. When you correct the acidosis, they enter inside the cell, leading to sudden hypokalemia. So potassium level should be monitored when you are treating the acidosis. Now coming to our 4 types of acid-base imbalances. First is metabolic acidosis. Metabolic acidosis is due to deficiency of bicarbonate ions. And why there is deficiency of bicarbonate ions? Because in metabolic acidosis, different types of organic acids are formed in the body, mainly the ketone bodies like acetoacetic acid, beta hydroxybutyric acid, lactic acid, or some other organic acids are formed. They increases the production of H plus ions. To neutralize these H plus ions, bicarbonates are utilized. Therefore, there is deficiency of bicarbonate in metabolic acidosis. Same is written here. When there is excess acid production, the bicarbonates are utilized in buffering. Three types of metabolic acidosis: metabolic acidosis with high anion gap, metabolic acidosis with low anion gap, and metabolic acidosis with normal anion gap. What is anion gap and what is in by high, low and normal anion gap? That you will see my previous lecture, and then you see this lecture, then you will understood. So metabolic acidosis with high anion gap. Here in this case, these are the causes of metabolic acidosis with high anion gap. Diabetic acidosis. Here the production of ketone bodies increases, and these ketone bodies leads to increased production of H plus ions. To neutralize these H plus ions, bicarbonates are utilized. Lactic acidosis is the another cause of metabolic acidosis with high anion gap. Here, due to hypoxia or due to severe exercise, there is production of lactic acid in the muscles. This lactic acid also leads to formation of H plus ions in the body, and to neutralize the H plus ion, bicarbonate ions are utilized. So there is deficiency of bicarbonate ion. Renal failure. So in renal failure, there is decrease in sodium and hydrogen exchange. So this, if you see this exchange in this mechanism, if you see in from PCT, H plus ions are excreted into the lumen, and from lumen sodium ions are absorbed into the PCT. So this mechanism is hampered. So what will happen? H plus ions are not excreted through the urine. Therefore, they are retained in the body. And if these H plus ions are retained in the body, to neutralize these H plus ions, bicarbonates are utilized. So metabolic acidosis means deficiency of bicarbonate ions. Next is amino aciduria. You have studied the protein metabolism. In protein metabolism, you have studied the metabolism of individual amino acids. So all amino acids are converted into their end products, and then they are utilized or they are excreted from the body. If there is deficiency of any of the enzyme during the metabolism of any of the amino acid, then that amino acid is not converted into its end product, or it is not utilized, or it is not excreted from the body. At that time, that amino acid is converted into its intermediate other acids. So again, the acid production in the body increases. To neutralize that acid, bicarbonates are utilized. So in metabolic acidosis, there is deficiency of bicarbonate ions. Organic aciduria. Here the concentration of methyl malonic acid and propionic acid increases due to metabolic defect. Okay, metabolic defect means deficiency of some enzymes. Here methyl malonic acid is formed when propionic acid is converted to succinyl CoA. And where you find this pathway? During beta oxidation of odd chain fatty acid. The end product you will get is one propionic acid is formed. That propionic acid is converted into succinyl CoA, and succinyl CoA enters into the TCA cycle. But the intermediate between propionic acid and succinyl CoA is D-methyl malonic acid and L-methyl malonic acids. If the enzyme converting the propionic acid to succinyl CoA and their intermediate are deficient, then methyl malonic acid get accumulated in the body. They are excreted into the urine. They are called as organic aciduria. Next is methanol poisoning. In methanol poisoning, after metabolism, methanol is converted into formic acid. Formic acid is a strong acid as compared to other organic acids like ethanoic acid, propionic acid. So it will gives synthesis. Formic acid leads to the synthesis of more H plus ions. To neutralize this H plus ion, bicarbonates are utilized. So metabolic acidosis means deficiency of bicarbonate ion. Again, last cause is drugs. Majority of the drugs on their after their metabolism for various types of acids, to neutralize this acid, bicarbonates ions are again utilized. Then metabolic acidosis with low anion gap. Here the causes hypoalbuminemia. Here hypoalbuminemia means decrease in the negative charge. When negative charged albumin decreases, to maintain the electrical neutrality, the chloride ions are increased, bicarbonates ions are utilized to neutralize the H plus ions. Normally what will happen when albumin is there in the body, at physiological pH albumin have negative charge, so that albumin combines with H plus ions and neutralize these H plus ions. If the concentration of albumin decreases, the H plus ions becomes free. To neutralize this H plus ion, bicarbonate ions are utilized. In multiple myeloma, it is a tumor of plasma cells. So here abnormal protein called as paraproteins are synthesized in the body. Their level in the extracellular fluid increases. These paraproteins have positive charges. These positively charged paraproteins in the extracellular fluid combines with bicarbonate ions, and there is deficiency of bicarbonate ions, leading to metabolic acidosis with low anion gap. Hypercalcemia, when the calcium level in the body increases, then this calcium ion decreases the concentration of sodium and potassium ions to maintain the electrical neutrality. So what is high anion gap, low anion gap and normal anion gap? That already I have explained in the last lecture. First see that lecture, then you will understood this lecture properly. Now metabolic acidosis with normal anion gap. In case of diarrhea and loose motions, what happen here is bicarbonate ions are lost in the body. When bicarbonate ions are lost, it leads to metabolic acidosis. Here anion gap is normal because the number of bicarbonate lost is equal to the number of loss of sodium and potassium ions, and I have given you the formula of anion gap at the top. Therefore there is no change in the anion gap. Next cause is renal tubular acidosis. In renal tubular acidosis, this mechanism is hampered. Kidney will not able to excrete the H plus ions. If you see this mechanism in the PCT, what is happening? H2CO3 is broken down to H plus ion and bicarbonate ions. H plus ions are excreted into the lumen, and through that they get excreted outside through the urine. At the same time, bicarbonate ions are entering into the plasma, means they are entering into the body. There is gain of bicarbonate ion in this process. So if this process is lost in renal tubular acidosis, body will not get the bicarbonate ions. At the same time, H plus ions are retained in the body, because by this mechanism they are excreted, and if this mechanism stops, H plus ions are retained in the body, and these H plus ions then utilizes the bicarbonate ion for their neutralization. So in this way there is deficiency of bicarbonate ion in renal tubular acidosis. Next is ureteric transplantation into large gut. All of us know ureters open into the urinary bladder, but if there is a cancer of urinary bladder, the surgeon will remove the urinary bladder. Then in that condition, these ureters are open or transplanted to the large gut. That means urine is collected into the large gut. So when this happens, what happens in the large gut? The bicarbonate ions are lost in the urine and chloride ions are absorbed. So there is deficiency of bicarbonate ions. And as the loss of bicarbonate is equal to gain of chloride, the anion gap remains normal. Next is acetozolamide therapy. In acetozolamide therapy, again this mechanism is hampered. This acetozolamide is a drug which inhibits the enzyme carbonic anhydrase. And this carbonic anhydrase is very important enzyme in this mechanism. If you see here, if this mechanism stops, again what will happen? In this mechanism, body is excreting 1 H plus ion into the urine and gaining 1 bicarbonate ion into the blood. If this mechanism hampers, the bicarbonate ions are not regenerated due to deficiency, due to inhibition of enzyme carbonic anhydrase by acetozolamide. So at the same time, H plus ions are not excreted, so they are retained in the body. To neutralize this H plus ion, bicarbonate ions are utilized. So there is deficiency of bicarbonate ions. So these are some causes of metabolic acidosis. After studying the causes of metabolic acidosis, we study compensatory mechanisms in metabolic acidosis. Compensatory mechanism is how body try to compensate this metabolic acidosis. So in metabolic acidosis, the ratio of bicarbonate to H2CO3 decreases. All of us know this ratio is 20:1. If you remember my first lecture of acidose balance, I have told you that the ratio of bicarbonate to carbonic acid is 20:1. So that ratio decreases. Now body try to maintain that ratio. So two systems, respiratory system and renal system, plays an important role to maintain that ratio to the normal. First we will see the respiratory compensation. When bicarbonate level decreases, the ratio of this decreases, then the body try to decrease the carbonic acid, so that ratio will again come towards 20:1. So how it decreases carbonic acid? The carbonic acid is converted into carbon dioxide and water. So before that, what happens is, due to metabolic acidosis, there is stimulation of respiratory centers. Acidosis stimulates respiratory centers. H plus ion stimulates respiratory centers. So there is hyperventilation. Hyperventilation means increased rate of breathing. That is also called as Kussmaul breathing or Kussmaul respiration. During that process, carbon dioxide is lost from the body. No doubt you will get more oxygen inside, but carbon dioxide is main stimulator of respiratory centers. So carbon dioxide is lost. To maintain the carbon dioxide level normal, H2CO3 is broken down into carbon dioxide and water. So concentration of H2CO3 automatically decreases. And if you see there above, bicarbonate ions are already decreased in metabolic acidosis. Here respiratory system is decreasing the carbonic acid. Respiratory system is decreasing the carbonic acid, so that the ratio will comes to 20:1. But fall in H2CO3 would restore the ratio, but it is called as partial compensation. Why it is called as partial compensation? Because in metabolic acidosis, the primary defect is deficiency of bicarbonate ion. So here bicarbonate level decreases, right? Respiratory centers are not increasing that concentration. What they are doing? Respiratory system is decreasing the carbonic acid concentration. Why? To maintain that ratio 20:1 normal. So what are the main cause, that is deficiency of bicarbonate ion, is not corrected in this mechanism. Only the ratio is maintained. Therefore it is called as partial compensation. Now coming to renal compensation. Renal compensation is called as complete compensation. Here there is kidney start excreting more and more H plus ion and increases more and more bicarbonate ions. The main defect is in metabolic acidosis. If you see the causes, diabetic acidosis, lactic acidosis, these are the causes due to which H plus ion is accumulated in the body, and to neutralize that H plus ion, bicarbonates are utilized. So kidney will stimulate this mechanism. So in this mechanism what happens? More and more H plus ions are excreted from PCD to lumen, and more bicarbonates entering from PCD to the plasma. So here the defect, what is the defect? Formation of 4H plus ion, deficiency of bicarbonate ion. Both are corrected, and hence renal compensation is called as complete compensation. The ratio will come to 20:1. Now more about renal compensation. Renal compensation sets within 2 to 4 days. Associated hyperkalemia is seen. I have just told you before that acidosis causes hyperkalemia because of some reason. So you have to monitor that hyperkalemia when you are treating the acidosis. Treatment of metabolic acidosis. First you have to stop the production of acids. If it is due to diabetic ketoacidosis, then you have to give intravenous fluids, insulin, and you have to give potassium supplement. Why? Because I have told you, when you correct the acidosis, there is sudden hypokalemia. Potassium ion from extracellular fluid suddenly enter into the cells. For potassium ions are important. Second, if there is lactic acidosis, you have to give oxygen inhalation and potassium replacement. In all cases of acidosis, potassium should be monitored. Potassium levels in the ECF, extracellular fluid, should be monitored carefully. Then bicarbonate requirement is calculated and they should be given. How to calculate bicarbonate ions for a particular patient, that you will study in your higher classes. After completing metabolic acidosis, now next is metabolic alkalosis. Metabolic alkalosis means primary excess of bicarbonate ions. Metabolic acidosis means the deficiency of bicarbonate ions. Here there is excess of bicarbonate ions. What leads to alkalosis? Alkalosis occurs when there is loss of acid from the body, or there is excretion of base from the body is defective, or excess base is added to the body. In all these conditions, bicarbonate ions are retained. So the ratio, which ratio? Bicarbonate to carbonic acid ratio is more than 20:1, opposite to metabolic acidosis. And I have told you, there is always hypokalemia in metabolic alkalosis. The reasons I have already explained you in the previous slides. Now sub-classification of metabolic alkalosis. Chloride responsive metabolic alkalosis, chloride resistance metabolic alkalosis, metabolic alkalosis due to loop diuretics, and metabolic alkalosis due to exogenous ingestion of base, which is often iatrogenic. Iatrogenic means during the treatment we are injecting more and more bases in the body. That is called as iatrogenic. So these are the four different types of metabolic alkalosis. First is chloride responsive alkalosis. Chloride responsive alkalosis simply means that when you give NaCl as a treatment, when you give chloride ions to the patient, the alkalosis is corrected. Therefore, it is called as chloride responsive alkalosis. Now, this type of alkalosis is generally seen after prolonged vomiting. During prolonged vomiting, what will happen? Acid is lost from the body. Or due to nasogastric aspiration. Nasogastric aspiration is done in patient after surgery. After surgery, patient is not given food for few days, or in case of intestinal obstruction, the patient is not given food by mouth, but acid secretion is continuously occurs in the stomach. So nasogastric tube is put from the nose into the stomach of that patient, and time to time the acid secretion is aspirated. That means again loss of acid. Next cause is upper GI tract obstruction. When there is obstruction in the upper part of the gastrointestinal tract, the patient again have acidosis because patient have persistent vomiting. So in all these above cases, there is loss of acid. Now you should know how loss of acid leads to metabolic alkalosis. This is the mechanism. See, this is the stomach, and I have shown a parietal cell. All of us know parietal cell synthesizes HCl. How parietal cell synthesizes HCl, the mechanism I have shown here. Carbon dioxide plus water gives carbonic acid in the presence of enzyme carbonic anhydrase. Carbonic acid is broken down into H plus ion and bicarbonate ion. H plus ion enter into the stomach, bicarbonate ion enter into the blood vessel, means into the blood compartment. To maintain the electrical neutrality or negative charge, the chloride ion enter into the parietal cell. When parietal cell will excrete the H plus ion into the stomach, they also excrete the chloride ion, so that one positive charge and one negative charge is removed from the cell and electrical neutrality is maintained. So in this way, H plus ion is HCl is synthesized in the stomach or secreted in the stomach. Now if this HCl is lost, so what will happen? This mechanism in the parietal cell occurring at more velocity, means it becomes more rapid. So it will synthesize more and more HCl, or it will secrete more and more HCl. But during that process, see what is happening into the blood compartment. Bicarbonates ions are added for in the blood compartment. Here HCl is synthesized in the stomach, and that HCl is lost into the vomiting or some outside. But that bicarbonate ion which is synthesized during the process of HCl secretion, that is retained in the body. So this causes metabolic alkalosis. Now in chloride responsive metabolic alkalosis, there is deficiency of chlorine. If you see this mechanism, previous mechanism I have shown, when H plus ions are secreted at the same time, Cl is also entering and HCl, both are lost. So chloride level in the body decreases. As the chloride level in the body decreases, there is decreased excretion of chloride in the urine, and hence if you measure the urinary chloride, they are less than 10 millimole per liter. So this test is important to distinguish between chloride responsive metabolic alkalosis and chloride resistant metabolic alkalosis. If urinary chloride is less than 10, that means there is deficiency of chlorine in the body, and if you treat this alkalosis by administration of NaCl, the patient will respond, or metabolic alkalosis is corrected. So urinary chloride value, remember, less than 10 millimole per liter in case of chloride responsive metabolic alkalosis. Next is chloride resistant metabolic alkalosis. Here what are the causes? Hypertension, hyperaldosteronism, severe potassium deficiency, or Cushing syndrome. So in this case, generally what happens? The aldosterone level is high and it causes loss of potassium and retention of more and more sodium. So here there is defect in the renal chloride reabsorption associated with underlying causes, where excess of mineral chloride, means aldosterone activity, result in increased retention of sodium and increased loss of H plus ion and potassium ions at the renal tubules. Now how to distinguish this type of alkalosis, that is chloride resistant metabolic alkalosis? Again you have to measure the urinary chloride. Here urinary chloride level is more than 10 millimole per liter. Here more and more chlorine is lost into the urine because there is defect in the renal absorption of chloride ions. So more chloride is lost, and therefore urinary chloride level is more than 10 millimole per liter. This type of alkalosis does not respond to the treatment of NaCl. Therefore it is called as chloride resistance metabolic alkalosis. Loop diuretics, all of us know, already I have told you. Diuretics means the drugs. Loop diuretics are the drugs which acts on the renal tubules and prevent the renal tubules from absorption of sodium ions. Therefore sodium ions are lost. sodium, potassium and chloride ions are lost due to this drug. When there is loss of sodium, all of us know it leads to secretion of aldosterone. Now this aldosterone then try to absorb more and more sodium by acting on DCT and collecting duct. But at the same time it causes loss of potassium ions. So this leads to hypokalemia. Whenever there is hypokalemia, that means decrease in the potassium ion of ECF, in that case, in the distal part of renal tubules, generally sodium are reabsorbed in exchange with potassium. In PCT, sodium are reabsorbed in exchange with H plus ion, but in the distal part of renal tubules, small amount of sodium is absorbed in exchange with potassium ions. As there is hypokalemia, potassium ions are deficient. So kidney will exchange in the distal part. Kidney will exchange sodium with H plus ion again. That means there is exchange of sodium and H plus ion at PCT. Normally, there is exchange of sodium with potassium in the distal part. Normally, that exchange in the distal part of tubules is hampered due to deficiency of potassium ion, and there, instead of exchanging the potassium ion, kidney will exchange the sodium ion with H plus ions. Means more and more H plus ions are lost. They will lead to metabolic alkalosis. I have already told you, exogenous, if you give exogenous base, then it will also leads to increase bicarbonate concentration. For example, during the treatment of metabolic acidosis, I have told you that you have to calculate the bicarbonate requirement of a patient, and then you have to give that much bicarbonate to that patient. But instead of that, if you are given large amount of bicarbonate to the patient from metabolic acidosis lands into metabolic alkalosis. Massive blood transfusion also causes metabolic alkalosis, because the stored blood contains an alkali and anticoagulant called as sodium citrate, which is basic in nature. Antacid tablets, which generally neutralize the acids present in our stomach, if they are consumed in large quantity, for example Gelusil is an antacid, they contain bases to neutralize the acid. If you are consume this in large quantity of bases are absorbed from alimentary canal, and there is exogenous increase in the bases. Milk alkali syndrome, it is generally seen in person taking high intake of milk. High intake of milk causes hypercalcemia. Hypercalcemia leads to decreased secretion of parathyroid hormone, and due to which there is hypovolemia. If there is hypovolemia, then aldosterone is secreted. That aldosterone will absorb more and more sodium ions. This mechanism, more and more sodium ions are absorbed, and during this process, what happens? More and more H plus ions are excreted, because sodium and H plus ions are exchanged. When one H plus ions are lost in the urine, one bicarbonate ion is gained by the blood or plasma compartment or retained in the body. This contributes to metabolic alkalosis. Now coming to the compensatory mechanisms. Here the ratio of bicarbonate to carbonic acid is increased, because metabolic alkalosis is nothing but primary excess of bicarbonate ions or primary excess of base. Respiratory compensation. What will happen? When there is alkalosis, pH increases. When pH increases, respiratory center get inhibited. The rate of respiration decreases, so carbon dioxide is retained in the body. When the concentration of carbon dioxide is retained in the body, this carbon dioxide combines with water to form carbonic acid in the presence of enzyme carbonic anhydrase. So carbonic acid level increases. So in this way, respiratory system try to maintain the ratio to 20:1. Again, it is called as partial compensation. Why? Because in metabolic alkalosis, the basic defect is deficiency of bicarbonate ion, excess of bicarbonate ion, and that's why ratio is increased. Respiratory system is doing opposite to that. The respiratory system is not decreasing the bicarbonate ion. Instead of that, it is increasing the carbonic acid in the body to maintain the ratio. So respiratory system will maintain the ratio 20:1, but the increase in the bicarbonate ions, which is the basic defect, is not corrected by respiratory system. Instead of that, it will increase the carbonic acid and maintain the ratio 20:1. Therefore, it is called as partial compensation. Renal compensation. Renal compensation is called as complete compensation because it will correct the basic defect. Here, it causes increased absorption of H plus ion, increased excretion of bicarbonate ions. Means if the fourth mechanism where the kidney will reabsorb bicarbonate ion, that mechanism is decreased. So there is loss of bicarbonate. In this mechanism, what we are seeing is kidney will try to conserve the bicarbonate ions and they are absorbing the bicarbonate ions. But in metabolic alkalosis, this mechanism is decreased. Therefore, there is loss of filtered bicarbonate through the urine, and in this way it will help to maintain the ratio 20:1. So there is complete compensation because bicarbonate ions are excreted through the urine. Next disease is respiratory acidosis. It is also called as primary excess of carbonic acid. It is a acidosis due to primary excess of carbonic acid. It is due to retention of carbon dioxide in the body due to hypoventilation. So whenever there is increase in the carbon dioxide in the body, this carbon dioxide combines with water to form carbonic acid in the presence of enzyme carbonic anhydrase. So carbonic acid level increases. Here again the ratio bicarbonate to carbonic acid decreases because denominator is decreasing. In metabolic acidosis and metabolic alkalosis, the numerator bicarbonate is affected, whereas in respiratory acidosis and respiratory alkalosis, the denominator, that is carbonic acid, is affected. So in respiratory acidosis, the carbonic acid level increases and the ratio is decreased. Now it may be chronic condition or it may be acute condition. It may be acute respiratory acidosis or chronic respiratory acidosis. So these are the causes of acute respiratory acidosis. Here first is bronchopneumonia or pneumonia. What is pneumonia? All of us know there is collection of fluid into the alveoli. So due to that fluid accumulation in the alveoli, the exchange between carbon dioxide of body and oxygen present in the air will not take place, or it get hampered or it get decreases, due to which carbon dioxide is retained in the body. Status asthmaticus. It is a condition where patient is suffering from asthma and there is status asthmaticus, means the patient have severe attack of asthma. Asthma means again narrowing of the respiratory passages. That means primary bronchus, secondary bronchus, tertiary bronchus, they get narrow, and due to which there is difficulty in respiration or difficulty to excrete to expel the carbon dioxide from the body. So carbon dioxide is retained in the body. Narcotics and sedative drugs, when they are consumed, they causes depression in the respiratory system, respiratory centers. When there is depression of respiratory centers, rate and depth of respiration decreases. So carbon dioxide is retained in the body. Bronchitis, inflammation of bronchus, again the same. Air passages becomes narrow. Paralysis of the respiratory muscles may be seen in many various cases like tetanus and others. So in this case, rate of respiration decreases, so carbon dioxide is not expelled from the body. CNS tumor or tumors, they also causes depression in the respiratory center. Ascites, peritonitis, sleep apnea, this also causes the retention of carbon dioxide in the body. Ascites means accumulation of fluid in the abdomen. Peritonitis means in the peritoneum. They are little bit similar conditions. Due to accumulation of that fluid in the abdomen, the respiratory rate is hampered, because if you see, when we respire, the chest as well as abdomen will move forward and backward. When there is accumulation of this fluid in the abdomen, then that respiration become more laborious, and so the rate of respiration increases. In sleep apnea, in some patient, when patient is in sleep, normally they will breathe, when they are wake up, they will respire normally, but in sleep their respiratory rate decreases. That condition is called as sleep apnea. So when respiratory rate decreases, retention of carbon dioxide in the body. In chronic respiratory acidosis, the main cause is COPD, chronic obstructive pulmonary diseases. Due to so many causes like emphysema, cigarette smoking, our respiratory passages damage, alveoli get damaged. It is a chronic condition. Or the patient working in some industries, due to inhalation of dust, their respiratory passages and alveoli get damaged. So there is decrease in the exchange of gases will takes place. Asthma is sometimes, it may be acute or it may be chronic. Now compensatory mechanism, there is no respiratory compensation in respiratory acidosis, because here the respiration itself is affected. So respiratory compensation is not effective in this case. Coming to the renal compensation, H2CO3 level is more, so kidney will excrete more and more H plus ions, increase absorption of more and more bicarbonate ions. When H plus ions are excreted, what will happen? See, when H plus ions are excreted, then H2CO3, to maintain the concentration of H plus ion, H2CO3 is broken down into H plus ion bicarbonate ions. So carbonic acid level decreases. So when carbonic acid level decreases, carbon dioxide combines with water to form carbonic acid to maintain the carbonic acid level constant. So in this reaction, remember the concentration of concentration of carbonic acid, concentration of carbonic acid and concentration of H plus ions remains parallel due to this equation. In respiratory acidosis, CO2 is retained in the body, right? So that CO2 is converted to H2CO3. H2CO3 is broken down into H plus ion and bicarbonate ions, and these H plus ions are excreted by the kidney. And last is respiratory alkalosis. Here the primary defect is deficiency of carbonic acid, and it is generally due to hyperventilation. Excess of carbonic acid is due to hypoventilation, that is respiratory acidosis. Deficiency of carbonic acid is due to hyperventilation, which is called as respiratory alkalosis. Here the ratio of bicarbonate to carbonic acid increases. These are the causes of hyperventilation leading to respiratory alkalosis. Hysterical hyperventilation, excessive crying, when these are generally seen in newborn babies or small babies. Because of excessive crying, more and more carbon dioxide is expelled from their body. So there is deficiency of carbon dioxide, remember, in this case. Second cause is high altitude. When you go at high altitude, the oxygen concentration is less. So there is hypoxia in the body, or body tissues are not getting enough oxygen. So this stimulates the respiratory center to respire more, to get more and more oxygen inside. But when you take more air inside, or when you take more oxygen inside, at the same time you have to expel the same amount of air, and in that air the carbon dioxide is removed from the body. Febrile condition means when you are having fever, temperature. You have seen, if you have seen or if you have experienced, when you are having fever, your respiratory rate increases. So during that process, what will happen? When the respiratory rate increases, more and more carbon dioxide is removed from your body. So hyperventilation is nothing but deficiency of carbon dioxide or deficiency of carbonic acid. Septicemia, meningitis, congestive cardiac failure, raised intracranial brain injury, all these causes hyperventilation, increase in the respiratory rate. Then early stages of salicylate poisoning causes respiratory alkalosis due to stimulation of respiratory center. Salicylate is a drug, group of drug. First, when it is metabolized, it will stimulate the respiratory center, leading to increase in rate of respiration. So more and more carbon dioxide is washed out from the body. But later on, after metabolism of this salicylate, various acids are formed, and the patient from metabolic alkalosis go to metabolic acidosis. This you have to remember. And now the compensation, here the carbonic acid to bicarbonate to carbonic acid level increases. Respiratory compensation here, increase in the pH, metabolic alkalosis causes inhibition of respiratory center. Inhibition of respiratory center causes hypoventilation and retention of carbon dioxide. When carbon dioxide is retained, this carbon dioxide combines with water to form carbonic acid in the presence of enzyme carbonic anhydrase, and in this way the ratio 20:1 is retained. So this is called as complete compensation. Why? Because here basic defect is deficiency of carbonic acid due to deficiency of carbon dioxide. So here the respiratory system is increasing the concentration of carbonic acid. Therefore whatever defect is there, that defect is corrected by the respiratory system, and hence it is called as complete compensation. Renal compensation is again increase excretion of filtered bicarbonate ions and decrease excretion of H+ ions is seen. So alkaline pH will favor increased binding of calcium to the protein, resulting in decreased ionized calcium, leading to paresthesia. This you have to remember. Whenever there is alkalosis, patient may complaints of paresthesia. Paresthesia means altered sensations. Why there is altered sensation? The ionized calcium level decreases in the body, because in alkalosis the calcium binds with proteins, more and more calcium ions binds with proteins. So there is decrease in the level of ionized calcium, which leads to paresthesia. And lastly, how to assess this acid base parameter? All of us know the name of this instrument. The assessment of acid base status usually done by arterial blood gas analyzer. This will measure pH, pCO2, partial pressure of CO2, partial pressure of oxygen directly by means of electrodes. It will also measure bicarbonate ion, chloride ion, sodium ion and potassium ion. By these 4 electrolyte you can calculate the anion gap. Most critical care analyzer estimate the blood gas, electrolyte, and they calculate their anion gap. And if you want to remember, these are the normal regions of various acid base parameter: pH 7.4, bicarbonate normal concentration 20 to 26 millimole per liter, chloride 96 to 106 millimole per liter, potassium 3.5 to 5 millimole per liter, sodium 136 to 145 millimole per liter, PO2 partial pressure of oxygen 95. It ranges from 85 to 100 mm of Hg. Partial pressure of carbon dioxide 40, it ranges from 35 to 45 mm of Hg. So this is about the disorders of acid-base balance. Thank you very much.